lead concurrent monitoring and a learning department, Bihar Technical Support Program, Care India. He did his MBA from Burdwan Medical College, West Bengal, India. PhD in Epidemiology from University of California, Los Angeles, and Fielding School of Public Health. He has extensively worked with Indian Council for Medical Research, International Vaccination Institute, Seoul, Korea, Japan. Japan International Cooperation Agency, University of California, Los Angeles, and others. He has conducted several research and consultancy projects on public health, epidemiology research and implementation, and supported building skill sets and research capacity for several national and international organizations. Currently leading a structurally embedded but a functional independent large unit, designing several operational and transactional research studies for informing public health program implementations, translating the wisdom gathered based on the conducted researches for greater common good, and generating evidence to help policy making. More than 140 peer-reviewed publications in reputed international journals. I request Dr. Tanmay Mahapatra to proceed. I would request you to take the session for 40 minutes so that we can have a Q&A for next 20 minutes. Thank you, sir. Over to you.
Thank you all. It's a great opportunity to be here and discuss something which just coming after lunch probably is not the best time to discuss something related to data. But I would like to start from where our respected Dr. Madhulankar finished. He mentioned that we need to look at data. And he mentioned that this particular pandemic scared us. Let's see, how does that scare work? Today, I'll tell you a story. Frankly speaking, these slides are actually the summary, not really that brief, of our last 8 months' work in Bihar. I'm originally from West Bengal. I'm working here as the team lead of Care India's work with government of Bihar, working closely at the Bihar Technical Support Program, which works for generating evidence wherever there is an intervention. Now, everything was going fine. It was 2020. We were supposed to evaluate everything to understand that how things are going. Then came COVID. How we were prepared about that, we all know. We were about to buy land in March, right? And that time something which you cannot see made all of us behind masks. Now, Bihar has a story to tell. And today we learned from our seniors that where from in the whole world this particular pandemic spread, it gave some kind of idea, and then it took us through the journey and taking us through till now. So Bihar started with planning for different kind of projections, and different organizations were asked to develop different projections which can be translated into operational work in the ground. Our government asked us to do something. We started with some initial number of cases, and then we came up with a model which we didn't know whether it is going to work or not, because nobody wants to see the projection model to work, because we want to defy that model. Interestingly enough, there were two models which were developed. One which was a little conservative, keeping in the idea that because of something will be different, not Delhi, not Germany. And another one, we were thinking, we were learning, we were hearing migrants are coming as if there is a new casteism, migrants. And that is going to change all the scenario. And that's why there was a risk that if migrants bring the infection rate and disease rate, the pathogenicity and infectivity of the places where from they're coming. So these two models are talking about that. Interestingly enough, when actually things happen, the the projected and actual were tough to differentiate. And that model was based on not only some, as we all know, the CIR model, its modifications, its different kind of, it was a Bayesian statistics-based model with accelerated nested mean model with 45 different models thrown into it, and it gave us some kind of idea closer to what we were seeing. Not the truth, because truth nobody knows. We don't know how many asymptomatic cases were there, how many cases we missed. Somebody was asking about the unknown deaths, or I was talking about the all-cause mortality. But this is what we had to deal with, the symptomatic cases. Based on that, the whole health system tried to come up with different kind of ideas, how to handle this. We had to understand how system is working. So there are different methodological slides here. I don't go into the details of those. We can come there in the discussion section after this presentation. We had developed, because as everything was under the lock and key, we had to be locked down, but we needed to know what is happening in the ground. So everybody in the research fraternity tried to brainstorm to come up with newer ideas of data generation, newer ideas of diversity. So we developed an in-house platform where our ground level team, who are anyway working with on the ground with the government forces, were meeting different service providers. There was an audiovisual platform just like what we are using here today, where it was being told that, sir, can I just have a few minutes of yours and we can discuss something, how we were facing all this, how we were coping with the situation, and what is your mitigation plan? And if you agree, our state team can join with you with this and we can discuss something. So it was a scenario capture. There was system-enabled process of collecting observation checklists, quantitative data, as well as qualitative information through real-time post-coding by people who are sitting at different places. We called it prism of planning study. We interviewed about 500 service providers of all repute across the country, across the state. We came up with different information that during pandemic, government was trying to arrange for different kind of trainings. Training through Zoom platform, over phone, different kind of trainers of the trainers in advance, some logistic arrangements prior to something being planned, different guidelines were planned, and these kind of different planning were going through different states, coordinating with GUI plan as well as GOP plan. During that time, there were challenges because my story today is the story of challenge. This information will be in the background. I will tell you a story how fear work in different direction. There are challenges in community, there are challenges in networking, there are challenges in the comprehension, there are lack of smartphones and unfamiliarity with different platforms. Still, our ANC services started to come up when unlockdown started happening. During that time, all the challenges from the frontline workers were known through this prism of planning study, and we knew that no ANC was actually happening during early April, but commuting difficulties faced by ANM was also a big challenge. So it's not only the community, not only the community members, but also the service providers going through the same platform of different kind of standard stones that brought them on the same page. I will notify a few points to be kept on mind for further discussion. There were other problems like the pregnant women. They were scared of coming to the ANC center, getting tested. There were all kind of difficult perceptional problems. There were no receipt of incentive of ushers that they were reporting. A lot of kind of things were happening around. But frontline workers themselves made some assumptions and they made accordingly some adaptations. They had to do some home visits. During that home visit, they were facing different kind of resistance, community resistance, because the community response was not that well built. We were listening more from media rather than from different kind of guidelines. And guidelines were changing before they were being read. So there were big problem regarding whom to believe. And during that time, it was a big problem to understand that under these assumptions, what the community can be actually expecting. They were expecting some different service products, family planning commodities, IFA tablets. So there were plans for those who had to visit for contact tracing and other kind of quarantining identification requirements. They started carrying those particular commodities. And then these adaptations are there mentioned in those qualitative interaction and those mixed method studies that we conducted, which actually told us that some mitigation plans were coming from the ground. The journey was something like this. So the challenges were about self. I don't want to go out. About from my family members, they don't want me to go out. And from me for the family members, I don't want to be a risk factor for them. Then the impact was the overall HR rationalization got completely dismantled. There are different kind of absenteeism, different sickness, and all kind of one task being given to another. So given all these, the situation got really tough to handle. And there was also the issues with the quality of engagement. If I'm worrying all the time, if I'm scared, how come I'm going to serve? Given all these, there were some mitigation plans coming from the system. Interestingly enough, second point to note, it's not always top down. It's not always state was asking the ground to work like this. They decided to have some kind of interactions, and we always talk about the problem of convergence between ICDS department, health department. Interestingly enough, they all were on the same page at that time. When we conduct different kind of studies, about 17,000 plus mothers interview of 0 to 2 years old children every year. And we always see that actually the Anganwadi workers visit a little less than the ASHA's visit overall, the way the state frontline worker service is received. But this time we saw they were going hand in hand, and their supervisors, superiors started communicating with them much more. They wanted to actually get them motivated and work with the team. They came regularly to meet them and make visits to the villages. Sometimes they were made to visit, sometimes they visited, but it worked. How it worked? So we had to then go. So it was a system level lens. As I told you, we are going to summarize the findings. So far I spoke about the system lens through this mixed method approach to understand what was the scenario, what were the intrinsic barriers, what were the intrinsic mitigation plans coming up, and how those were actually implemented in the ground. Then we wanted to understand those things from the frontline workers. So we conducted a telephonic survey about 5,000 frontline workers were actually interviewed over phone, and we assessed their knowledge regarding different things about coronavirus. Why we found that spitting, different kind of touching of the common surface, avoiding crowded places, staying at home as much as possible. These points were unpromptedly mentioned less. They were more worried about hand washing. And we always talk about infection control. We always talk about the behavioral change in hand washing and all those stuff. See, for that we need a pandemic. So we found that, and this also has come, I will not show those data today, but from our facility assessments and our different kind of direct observation of delivery and other facility level studies, we have seen that overall infection control practices have actually improved during this period. I will not go all details of this because again, it's not best time to discuss of the nuanced data, but I'll tell the story. So we spoke about behavior change being scared. Now, frontline workers reported about their workload, and about 90% of them were involved in providing some information regarding COVID into somebody in their catchment area. About 82% of their of themselves collected data regarding their catchment area, regarding the contact tracing, migrants, and all other things. And they also conducted household survey. About 3/4 of them were engaged. We must be aware of the social desirability bias in this data because there will be some over-reporting as it is self-reported data. But we have our ways of actually record-based recapture of the data and consolidate the information, and it's that what I am presenting. And while managing the COVID quarantine center, they were less engaged. So overall, it was found that Ashas and Anganwadi workers had more interaction with beneficiaries at home, while ANMs were involved more in the managing the quarantine center as expected. But this is all about what they are doing, what's happening to them. So we found that about 56% were worrying about loss of employment or loss of income in their household. About 1/3 of them were having trouble because they are having shops closed in their vicinity. And long distance travel restriction were affecting 1/3 of them almost. While 1/5 of them were complaining about burden of additional work and fear of household members getting sick as expected. So the next point is about the challenges of frontline workers in providing services during lockdown. And this is coming from themselves because they mentioned that they were facing community resistance, they were having some inherent fear, and they were having discomfort wearing masks, as every one of us. So the perception of the community was something like that the FLWs are the potential carriers. They are expected to carry medications and food for them. And there are suspicions that they were also collecting information regarding something related to CA and all other stuff. And there was also some mitigation plan. As I told you, the involvement of the PRI members and other block level officials in this particular process helped them to get more empowered, which we are trying to have done through the systematic approach for long, but pandemic helped. And on the other side, the personal visits by MOICs and DCM and health officials wherever happened, that helped a lot. And the awareness were tried to be improved as much as possible through miking and other IEC material. Family resistance, as I mentioned before, were quite high, as well as lack of transportation were complained by many of them. But these kind of resistance varied across the cadre and differential barriers for differential groups like Ashas and Anganwadi workers facing more resistance because they are coming actually more in contact with the people at community, whereas ANMs always complained about the problem of the transport because they have to travel more. Now, let us see what actually was the service scenario. It was disrupted. It is probably talking about immunization services. So it was disrupted during early April, but it resumed and reached up to 87% during July through the VHSND platforms. And 34 out of those who were interviewed, they were actually found that they were reminded. Our home visits were more through phone calls, more than phone calls. And so the 26% were teamed with other FLWs. I again inclined to remind you about the convergence component. So they were teaming up with other FLWs to kind of carpooling or something to reach the venue. And then there were also 1/5 who were actually not happy that they couldn't do much. Whereas while talking about engagement in VHSNDs, it was only 1% of them who mentioned that they were engaged in VHSNDs, but that was in April, whereas it reached up to almost 90% during July. And it was more for ANM, little less than the others, a little less for the others. The adaptations that they actually made while providing service during conducting the VHSNDs definitely tried to maintain some physical distance and self-protection and organize the VHSNDs in separate groups and timing. And here I again want to remind you how local solutions help to handle the pandemic scenario in the ground. These local coping mechanisms must be kept in mind because we always not actually be having a pandemic to teach us. We need to be taught earlier so that we can handle pandemic better. And then they were actually also trying to come up with other kind of solutions. And together we conducted some advanced analysis, some regression modeling, some multivariate modeling to understand that what were the different predictors of better performance of the Anganwadi workers. And it was found that those who are more experienced, they were more likely to perform better. Those who had better interaction with supervisor, they were 4 to 8 times more likely to actually serve better. Those who had better training, and here we are not talking about the training of Asha or Anganwadi training, we are talking about the training provided how to handle pandemic. They were actually felt more empowered, felt more safe, and that actually helped them to perform better. and protective gears is always a positive deviance. Whereas 3 or more work challenges, those who mentioned that they may have more challenges, they were performing better. It's actually a reverse causation, that those who are performing more, they are facing more challenges. And knowledge on COVID also was found to be a positive predictor. Now, together we found that other components that we always think, number of households that needed to cater, access to smartphone, etc., they were not that strong determinants. So where I'm heading towards slowly, because my ultimate objective to reach the persons at home, ultimately we are finding that the individual factors played better when we are dealing with such a scary pandemic. What about the ASHA? Things were almost same regarding the interaction with supervisor and adequate training. Other factors were not found that much strong predictor. We also conducted a homecoming study by interviewing about 14,000 households to understand that who came back. It's the homecoming study, the study about the return migrants. And we found that the return migrants, out of 13,435 successful interviews, we had about 70% household where at least one migrant returned. And among them, there were 10% who had at least one woman returning. Whereas the distribution was something like this, whereas we can find that the 6 months to 3 year children were about 5% families. Now, if we translate this into easier terms, of every 200 households, 34 had at least one returning person, one pregnant, lactating pregnant or lactating woman, and 2 children. Now, let us think about how they came and what was the distribution of the individuals. I spoke about the household before, and this is I'm talking about the individuals. So what was found that in those households, 79% returning people were men, whereas 8% were women and 13% were children among all those groups who returned. And altogether, there were 14,985 individuals who returned, and the percentages among the household and individual almost remaining the same. So there were guests at home. So of every 1,000 returning migrants, we have about 10 pregnant women, 5 lactating women, and 75 children. Now, what happened to them? They returned. After that, was there a reverse migration going back again? We'll come there. As I told you, part of our technical support, we conduct a study of multi-stage cluster random sampling of all, there is no sampling in the blocks. In all 534 blocks, we conduct this assessment of mothers of 0 to 2, 3 to 5, 6 to 8, 9 to 11, and 20 to 23-month-old children. It's overall a 78,000 plus sample size study. This is the first time we could actually go to the in-person interviews at home, and it has been conducted during October, November, December. And this is exactly what I want to present to you. This is very interesting. We all know that there were problems. There are problems in ANC, there are problems in receiving services through frontline workers, receiving counseling through frontline workers, and there are different kind of internal scare. How did that work? That came from this study. Now let us first think about frontline workers service. It was found that mothers in the household where any family member were COVID infected, they were more likely to be visited by FLWs. So ultimately, my rest of the presentation can be summarized into 3 lines. Number 1, COVID took all the attention. Number 2, COVID made everybody thinking more about health. And number 3, wherever there is an availability of something, the usage improved. But if there is nothing, can't be helped. So dietary diversity was decreased. But rest of the things were something like this. Regarding frontline workers, the whole health system is trying to improve them through all kind of building their resilience, building their motivation, trying to come up with different technological platform. But ultimately, it was found that if there was anybody in the family who are COVID infected, frontline workers were almost more than 2 times likely to visit them during last trimester, anytime during pregnancy, within 24 hours post-delivery, within 3 months after delivery. Regarding the antenatal care, mothers who reported that some members suffered from COVID, they were more likely to be advised on antenatal care. They are more likely to be advised regarding the wearing of mask while going for the antenatal care, as well as initiation of complementary feeding. Same happened regarding that was about the mothers suffering from COVID were more likely to be advised regarding the wearing of mask and antenatal care, whereas those who had restricted mobility, those who reported that they had reduced social support, they were receiving more advice from the frontline workers. Because we have seen in our other studies of social vulnerability and the vulnerability assessment feasibility, that means how many of the frontline workers know about their catchment area, we found that almost 90 to 95% know about them. They know which house is having domestic violence. They know which house doesn't have any person in the house, male person, to take care of the baby. So ultimately, it was not surprising that wherever there is a reduced social support, they are actually going to face the more frontline workers. On the other hand, while we are talking about the mothers who had family members who stayed quarantined or had some pre-existing illness, they were also having different kind of frontline workers counseling. Let's see, we always speak about institutional deliveries were not happening, everything got into a mayhem, and must be a lot of home deliveries happening. Let us see these graphs a little carefully. They will be showing you different lines, and based on our sample size and confidence interval non-overlap, there are differences definitely, but the values are 60 and 55. So we can see, as opposed to last year, it was actually not that much different. Interestingly enough, it seems like we were actually going to have a surge of childbirth during the start of the year, at least in the facilities, when COVID happened. So ultimately, the good part of the story is institutional deliveries remained to go up, even after this COVID, when the lockdown happened. And this is not from any record. The previous data was primary data. It was data from the households, from mothers who delivered. Now the question was, who were likely to use more ambulance? Who were going to have more, get their child delivered? And who planned better for institutional delivery? Mothers in the household who reported that they had COVID patients, they were more likely actually get fully immunized. Now you can relate. You can relate there is an infectious disease. There is an increase in the frontline workers visit, maybe for reminding for the immunization also. And together we are seeing that there is a statistically significant, maybe not meaningfully that much because immunization anyway is high. So ultimately there was an increase. On the other hand, use of ambulance, when we are seeing those who had some income loss, they have used ambulance for going into the facilities more. Whenever we are talking about the planning, those who actually understood that they are going to have some reduced social support, they planned for institutional delivery better. Where immunization reduced little bit when the families where there was less social support and members who actually had to stay quarantined, there the scenario is also same. We were talking about the households where we had migrants returning. Now, total number of migrants returned, we have already shared and we have already shared proportions. Now, interestingly enough, only 3.1% families reported that they have somebody still staying. And among them, what we found that the distribution of family members were something like that. But if we translate this into among 200 households, then we will find that there were one child and about one pregnant or lactating women staying back in Bihar in every 200 households. Now, I have 3 more slides. In these 3 slides, I'll talk about what I wanted all of us to ponder. How care works. 89% of the families were impacted by some way or the other. Majority of them had some loss of income. In the initial speech, our colleague were talking about the economic scenario. Problems with food supply were reported by more than 2/3. There were long distance travel restrictions to all kind of other problems, including poorer healthcare access and all other stuff. Now, having all these, the financial coping were something like this. The picture is really, really worrisome. Among those who borrowed money to buy food, 37% also had to sell their assets. And again, this is not coming from any record. This is reported data with home visit and other kind of information. So when shops were closed, 64% experienced some distress. And that is actually coming. We try to understand those who are mentioning that their expenditure reduced. How much was that because of shops remaining closed? And how much of there was because of loss of income? And we have seen the distress amount is quite high. Now, as we have seen that 68% had to borrow money to buy food, we can understand that there will be food insecurity. And the food insecurity, interestingly, definitely went up from 19% to 26%. But severe food security were actually strikingly low. So what happened? This food insecurity feeling, the importance towards actually thinking about nutrition changed. And why am I saying this? One data I will not show because it's very complicated, but I can explain. Interestingly enough, nutrition has remained throughout. I'm talking about child nutrition more. Nutrition has remained throughout a problem in Bihar because somehow dietary diversity is not moving. Initiation of complementary feeding is not reaching the level that we want. Frequency and quantity also remaining the same. Suddenly we are seeing during the COVID period, these things started actually improving, especially initiation and frequency. But dietary diversity went even down. Now that means if the next point which I mentioned that it is a little complicated and that's why I didn't put it here, but I just want to explain. By stratifying COVID infected and COVID not infected families, food insecurity, insecure families fed their child better if they were COVID infected members in the family. Whereas food insecure families didn't feed them that better if they didn't. So what I'm trying to say again, and I'll come to the conclusion of all these points that I wanted all of us to ponder is that scare. Now, rest of the things that we mentioned, that there were some food insecurity in many of the families, and families who had income loss, or they were actually somehow, they had lower breastfeeding, exclusive breastfeeding was less. So maybe something like, if we inculcate both information together, there may be a case that whenever there is a food insecurity, wherever there is a problem or there is a worry about the supply, maybe whenever something is there that have been fed to the child even before 6 months. Now, on the other hand, initiation of complementary feeding, age-appropriate meal frequency, minimum dietary diversity went up in the income loss, families who had income loss. Food supply constraints were there. So again, exclusive breastfeeding were everywhere. There was a felt perceived distress. But overall, the nutritional practices, even minimum acceptable diet, were found to be better for children aged between 6 months to 11 months, better than last year. And we are dealing with data from 2015, 2014 till date about these indicators. And we are seeing which was going like this, suddenly showing some increase. Whereas when we are talking about members in the household, this is just to ensure that we are not enough sleepy after the lunch. Can you tell me how these things actually affected the outcome variable? So what is the outcome variable which is going to come here? We all know. Increased arguments at the household and all kinds of complications. We have information on violence also. That's a little sensitive, so I didn't put here. So wherever there is a decreased earning, wherever the constraints in food supply, all kind of things actually, domestic environment got little kind of disturbed. Now, isn't it the time to make health more important for all of us? It's not the time that, again, I'm coming back to that statement that we were quite confident. We have taken care of Earth. We are going to Mars. Isn't the time to think about our babies? Isn't the time that our GDPs, how much proportion of that is going to be spent on health? We need to revisit those policies. It's time to think. Let's discuss. Thank you. Questions, please.
We can take questions for 10 minutes. She is going to join at 2:45 p.m. for a brief conversation. I was not able to come here, but he says today just about the PCM office and he wants to address us for a few minutes. So we can kind of, there will be a stop at 2:45, and after the speech, if there is any time, we can go for some more questions. I hope that is okay.
Perfect. The questions will continue to come.
Yeah, thank you, sir. Please go ahead with the questions, and once 2:45, please don't mind. Thank you. Super, I don't see any questions from the chat box, but anyway.
So you talked about the diet diversity. So what might have been the reason for this? Like, is the reason that when coming back to Bihar from for the migrant families, the regular traditional diet like sweet, burdwan, these things were included in their diet because they couldn't avail any other thing, or were they taught or they learned from somewhere about diet diversity?
So that's a great question actually. And interestingly enough, as I mentioned, that while 70% of the households had at least one migrant returning, only 3% of them had somebody actually staying after 1 month or so. So they were a very small proportion of this huge population that I'm dealing with. And when we actually got into this dietary diversity assessment, we found that it's not really different kind of cereal-based diets or something. It's actually whatever was available. So again, we actually gone into individual food details. And when we are putting it all together, we are seeing like that. But when we are seeing it by food insecure families, the food insecurity actually showing that there is a downward trend. So what was expected that is happening. But while feeding the babies so far, we could not let them know that go beyond those misperception and other stuff. This is actually was cold for the baby. This is hot for the baby. This is not something to be given to the baby. They've gone beyond those things. Whatever available, they started to feed. So exclusive breastfeeding gone down, but initiation increased and dietary diversity at some places. So that's our understanding. Not really different dietary habits. Thank you. Next question, please.
In the supplies of food grains on the Food Security Act, help in any way? I'm asking this because you have come out with counterintuitive findings. For one, and if you could also give us an impression of the samples composition in terms of socioeconomic background, actually extremely counterintuitive, particularly for very poor sections, people who are covered under the National Food Security Act. Often they have no savings and they come back. It does seem that they have used the savings to tide over. Yeah. So it would be of interest.
Yeah.
Samples composition.
So first of all, sample composition, it's actually a representative sample of the whole state of women of families who have under 2-year-old children. So it's from all 38 districts, all 534 blocks, It's a multi-stage cluster random sampling, and after that a systematic component starting with a random start. And this gives us the 7 years data shows us that the Hindu and non-Hindu population ratio and the caste distribution all remaining same. So if we have enough reasons to believe that representativeness is there over years for the last 7 years. So it's representative of rural Bihar. And that's how government of Bihar, the Bill Gates Foundation, everybody use this for the Bihar policy of this. So regarding the socio-demographic distribution, we have representation of the households as it is there here. And we have the socio-demographic distribution among these findings also, stratified analysis as well as other regression. The point again, it's not something which is going to be a long-lasting aspect. We are talking about initiation of complementary feeding. When we are talking about feeding, we are not talking about the whole family's feeding. We are not talking about the adult dietary diversity. We are talking about everything I spoke about here is the child nutrition. It's initiation of the complementary feeding. It's frequency of feeding. Now frequency increased, what we could not increase over last 5 years, 6 years, 7 years. That does not mean the quantity was enough. That does not mean it was having enough vitamins and minerals. But and we have those information. What the point is, I was scared. I was not scared. I was scared that tomorrow whether I'll have food to feed my baby. So I have given to it. This is what, and that's we all have done. I'm talking about food. Think about mask. Think about hand washing. All our personal hygiene is improved over the last 8 months, 9 months. So it's time to act on health. It's time to think about personal health. And it's time to increase our accountability about health, each of us. That was my point. Thank you. That's a nice question. I think we need to stop now. Any further question, I'll wait. My email ID is mentioned here. I'll accept questions over emails also. Thank you.